I'd now like to introduce our next speakers, Jacob Mullinex and Peter Corrales, as they will be presenting on psychiatric telemedicine in response to COVID-19. Jacob and Peter are both residents at Community Health Network's Psychiatry Residency program, and the program at Community has made a number of changes in response to the COVID-19 pandemic, and specifically changes to the residency structure include various telemedicine platforms to transition essential resident rotations to remote telemedicine. So with that in mind, please welcome Jacob and Peter for a presentation on this very innovative concept.
Welcome, everybody. My name is Dr. Jacob Mullinex, and I'm here with Dr. Peter Corrales. We're a couple of psychiatry residents at Community Hospital North, both second-year residents, about to be third-year residents. And we wanted to talk to you about how COVID-19 has affected our residency in particular, starting with some background of shortly about what some of the features of our residency were like prior to COVID-19, and then once COVID-19 got in its full array of motion here, what we have done to respond at the residency level for all of our 4 years. Peter, have you introduce yourself?
Yeah, so I'm Peter Corrales. Like Jake said, I'm a second-year psychiatry resident. And yeah, we will kind of talk about, how we operate first as a residency, because as a community-based program, we're definitely involved in a lot of the process changes at a systems level, but at the same time, we operate somewhat in parallel or independent from a lot of the bigger department processes. So there's some nuance there in terms of, how the hospital responded and made adjustments, and how quickly or slowly the residency responded as well. Sometimes we were ahead of the curve as compared to the rest of our hospital. Sometimes we were a little bit slower, just depending on what things were going on. So yeah, we'll kind of try to break that down a little bit too.
All right, and just starting out with some of the background on our residency. We are only the second psychiatry residency in the state of Indiana. We're located in Indianapolis at Community Hospital North and within the Behavioral Health Pavilion there. The Behavioral Health Pavilion has 123 inpatient beds spread across a whole variety of different units. A couple of youth units. We've got IR, which is for addictions, dual diagnosis of both addiction as well as like depression, anxiety, mental health diagnoses, affective unit, severely mentally ill, psychiatric intensive care unit, as well as an overflow unit and geriatric unit that's actually not technically community-based. It's subcontracted out. It's called our Seasons unit. We have currently 4 classes, and that's how long a psychiatry residency lasts, is 4 years. And this is our 4th year of program of existence. And so Peter and I are in the 3rd class at the residency, and we're going to have our first graduating class here in about a month or so. And
yeah,
oh, sorry about that.
Oh, just gonna say, yeah, then we also have our incoming class starting in July too, amidst all this. So, pretty hectic time for us for sure.
Oh yeah, but they've been experiencing it on the medical school side of things, and we're affiliated with our outpatient office, which is called Gallahue Hillsdale, which is located across the street from Community Hospital North. But we also have a lot of affiliated outpatient offices around the city, as well as state and in hospital settings that our residents do work. And just off the top of my head, I can think of Fairbanks, as well as the Neurodiagnostic Institute, which is a state hospital setting, Community Hospital South and East, Howard and Howard Regional area, and all the different community outpatient offices.
In terms of a typical rotation, just in terms of what a resident will often go through, some of this is pretty similar to what occurs on a national level, especially in the first 2 years. Those are pretty structured according to ACGME requirements that govern all residencies. So in the first year, we do half of the year is inpatient psychiatry on our main teaching service, and that's split up, in month chunks throughout the year. And then we do 3 months in total of family medicine in the inpatient setting. We do that in a mixture of Community South and Community East with their respective family medicine residencies. We do 1 month of ER, just general ER medicine, and then 2 months of neurology on the neurology inpatient consult service. For second years, we go into more of that subspecialty role. So the first year is just that foundation, kind of the bread and butter type of content. Second year goes into child and adolescent for 3 months, geriatrics, addictions, at Fairbanks for addictions, and as well as 4 months of inpatient psych where the second year is supervising over the first years and kind of learning to lead the service and do a little bit of teaching to both residents and medical students. For third and fourth years, we're mostly in the outpatient setting. A good amount of that time is at our Hillsdale office, which is very close to Community North Hospital. And then we also do a mixture of different other kind of outpatient rotations, such as our CSP clinic, which is our community psychiatry, as well as severely mentally ill population that we work with there. We do some inpatient consult liaison work, and then we do a number of electives that are scattered out throughout the third and fourth years. Could be a variety of different things. Getting experience with maybe more inpatient supervision, doing some neuromodulation, learning how to do TMS or ECT or our popular electives. Getting some more forensics and correctional psychiatry. So there's a lot of different things that our third and fourth years have been doing.
And largely, especially as we become fourth years, our electives are largely built around gearing us up for our careers in whatever specialty of psychiatry we're going into. And as far as I wanted to show an example, kind of outline of what our inpatient psychiatry service is like normally. This is all pre-COVID, and so we're again located at the Behavioral Health Pavilion at Community North, and our service has 3 residents. Our second year resident is our chief of the service, and then we have 2 interns or first year residents. Also have an attending physician that oversees and supervises our work, as well as 4 third-year medical students at a time from Marion University College of Osteopathic Medicine, located in Indianapolis, and a 4th-year medical student that's usually doing an audition rotation, kind of feeling us out as a potential residency for them. And they can be from all over the United States. We've had multiple from California, also all the way over to the East Coast and everywhere else in between. And usually our day starts out we pre-round on everything on patients before 7:45, but we have a 7:45 huddle that we kind of run through our list, and then we have some education from our pharmacists and pharmacy residents and pharmacy students that work with us. And then we kind of split off and go our separate ways and go round on all of our patients that are dispersed amongst all of the units except for youth and geriatrics, because those are different rotations. And then we kind of reconvene and get together and staff our patients with our attending physician. And in the meantime, when we're out seeing the patients, we're seeing them with usually a pharmacy student and a medical student. Mm-hmm. And after staffing our cases, we'll go back again and around as a team with our supervising physician for the final treatment decisions. And every Monday and Thursday at scheduled times, we have treatment rounds where we get together with social work, case management, nurse managers, utilization review, and we go through all of our patients to try to have a better interdisciplinary care for our patients. We also integrate a heck of a lot of education into our weekly and daily routines. We have case presentations by the residents every week, and then usually the last week of the month, med students will do one. And we also do lectures with the medical students every afternoon for about an hour or so. And we also have didactics every Tuesday, case or journal clubs, grand rounds, process improvement projects. And then a lot of us are on committees around the hospital as well. So our days are fairly busy, and we're on call by pager and put in some admission orders up until 5 p.m. every day.
So in terms of, first steps, when kind of making decisions and the process that we went through in terms of how to initially respond and what were our priorities in terms of everything. Safety was the biggest one, obviously, and figuring out how we're going to pull back, what's essential versus what could be done remotely, and even what things could be canceled if they were completely unnecessary or if they could be postponed. And we were communicating heavily with GME. So GME is our graduate medical education. Essentially, it's that structure that oversees all the different residencies within any given network. And so that GME, is a collective in terms of, our, program director in our program, along with the other family medicine and podiatry programs that are within community network. So we, a lot of coordination has to always go in terms of that GME network. The network overall as well. So even beyond and outside of GME, there's big network level decisions that were being made, and we have to make sure that we're aware, and kind of communicating that information down, through GME as well as to individual residents, and making sure that we're, not doing anything that's inconsistent with each other, and trying to remain in tandem with everybody. And then the pavilion. So pavilion, although our network and bigger system is kind of making big changes, us as a pavilion and being kind of a pretty, on-site connected to the main hospital, but also kind of a autonomous, building in a way that there's a lot of our kind of administration that we have to think about in terms of the staff, the nurses and techs, and even maintenance that's in the building, everyone that's going in and out of it. A lot of that is just more of a local leadership and administration. So a lot of coordination there, and how residency is kind of a piece of a puzzle in that.
And I'm just going to add, just like Peter said, there was a lot of work going on behind the scenes for a couple of months, really, and before it was brought forth to a lot of us residency, maybe of the residents, how much work was going in terms of meetings and information sharing and planning, before even acting on things. But I do recall it was just a weekend in mid-March. I was on my addictions and emergency psych rotation, and I got a call from our program director, Dr. Cunningham, and she's like, "Don't go in Monday. And here are the essential and non-essential rotations. You're on a non-essential." And so yeah. So
I remember that too. I remember hearing that our program director and our incoming associate program director, that one weekend in March, they were working 10, 12-hour days for that entire weekend, and then we finally get a call on Sunday. I remember on Friday at the end of the day, we had no idea that anything big would change, and then that Sunday was like, all non-essential rotations were being stopped and things were moving very quickly. so yeah, there was just a lot of meetings in a small amount of time, especially when that first started. And I as well got a call and was pulled off of my child and adolescent rotation, really abruptly within, even just 12 hours before, I was planning to go in. So a lot was moving quick.
And this is somewhat building on, and we'll kind of go through all of these step by steps, but a lot of the changes that had to take place, and we've mentioned essential and non-essential rotations, and we'll go through what those were. We had to adapt in terms of being remote. How could we start seeing patients again and increase patient access to care via telemedicine and different platforms there? And then there's how do we continue our didactic learning, and how did residents' roles within the network and the pavilion and the residency in general change, and how much involvement from them were we getting? And then at one point we had some redeployment even of second year residents. Fortunately, I did not have to be redeployed. I was scheduled to do so into our inpatient hospital wards at Community North, but Dr. Corrales was, along with Dr. Martinez, and they spent a week, a 7-day, 12-hour shift seeing hospital inpatient medicine patients.
Even that whole process was very in depth, because they, initially it was okay, all volunteers, anybody who was interested in kind of potentially being redeployed, they could sign up. And then they kind of progressed to we really, really highly encourage people to fill out this form. And then from a GME level, it was we pretty much expect all residents to offer, the potential of being redeployed. And especially because so many of us were, at that point in time, they realized we're probably going to be pulled off of certain rotations and would potentially have that flexibility to be redeployed. So we kind of escalated I remember just in a short amount of time, they amassed a huge list of providers that could be redeployed. And, residents were, pretty high on that list just because we have all that inpatient experience. And they were pulling, providers from the outpatient setting along with residents in kind of a cohort or little pairs or a team, because a lot of the outpatient physicians didn't have the most up-to-date epic knowledge in terms of order sets and admission orders, and just how to do that electronically in the EMR. And so we were used in a lot of those ways, as well as to kind of manage the increase in volume that we were getting in the hospital. So then that's how it worked when I was redeployed for that week. I was working with an outpatient physician who had been working with the network for a couple of years, but never did any inpatient work outside of his residency, which was over 10 years ago. So it was very helpful, for him to have me and help him out with any of those orders and, things that were standard and in terms of what's on formularies, things like that. So that was, that in and of itself really was a big process that helped us to kind of handle that huge wave of patients that we got that were coming in, with COVID. And from what I even saw there, it was, our total numbers were down because we were really being selective with who we admitted, but our proportion of COVID patients was very high, 50% if not higher. So yeah, our entire hospital on the medical side really had to change and adapt to that.
And building off what Dr. Corrales was saying, the reason it was the PGY2 singled out for that was that our first years had not had sufficient medicine rotation training yet. And then our third and fourth years had continuity clinic that had resumed via telemedicine, so could not join in. So we were sort of the luck of the draw there.
Yeah. And I think the non-essential versus essential, I know there was a lot of behind the scenes, and I was, maybe part of that, some of that decision making, but that was pretty much made at a much higher level with the director of our GME, along with the main leaders in our network. We're trying to figure out, well, we want to minimize exposure, but we also need certain services to run, and residents are the residency service, especially in the inpatient setting, is pretty essential to keeping our behavioral health pavilion running. So trying to figure out, well, where can we spare residents and pull them off of to minimize exposure, but how, also how do the residency services and patients that they're seeing, how does that play into how we're responding in this greater situation?
And also there were some new opportunities that arose from this whole experience and continue to come from this experience, as hard as it's been for everybody, whether you're in healthcare or not. And then also importance of continued wellness, and we've been stressing that as a residency program.
Mm-hmm. Yeah. So I kind of jumped ahead on that one. So in terms of more in what we decided was essential versus not essential. So our essential services, like I was kind of saying, was our inpatient service was, our main bread and butter. What for our residency is pretty important for teaching, but also is important for keeping our greater pavilion running and handling the volume. So it was both something that we wanted to make sure that we were keeping for maintaining our learning, and it was also something that the administration really valued and needed us to kind of continue. So there, that was a no-brainer for sure. Our consult liaison service was, more of a debate. That's where our residents, as well as faculty, are seeing patients on the medical side that have some kind of psychiatric need or need some advice on where they should go, whether they should be, admitted to inpatient psychiatry or not, and answering some of those questions. It felt like that was, important because it is an inpatient service. That's still something that's going to be pretty valued, even with, more patients being, kind of, even though there was more of a focus on COVID, it's still been a pretty high volume service. And then emergency psych crisis. So our crisis staff was getting, a huge amount of people coming in. The more unemployment that we're seeing in the community, the greater numbers our crisis has seen, and so they really needed that support from residents to try to ease the load off of our crisis staff. So we kept that going in the evenings, as well as weekends. We somewhat had to minimize that depending on what was changed. So the second years being redeployed, they were pulled off of crisis just because there was obviously overlap with the shifts, and also kind of a focus on wellness too. So that was kind of a dual reason why some of our residents have been thinned out in that crisis, for those crisis shifts. And then outpatient clinic, as Jake mentioned, was very essential. We're trying to maintain our volume in terms of all the patients we're serving, and seeing patients in the outpatient setting is hugely important to try to minimize patients that are coming into the ER, coming into our crisis center, and trying to keep people as stable as we can in the outpatient setting. And in the residency, outpatient clinic sees quite a lot of volume, so that would have made a pretty big difference if we were to shut that down. And then first year resident medicine. So initially, there was some flux there in terms of our residents. So our residents being psychiatry residents, we only kind of rotated onto other family medicine services. So initially, those services were thinned out by their respective programs, and so for I believe maybe about a month, we weren't over there rotating with them because they had limited their residents to maybe only 2 on at a time, as opposed to 3 or sometimes 4 that they would have. So it kind of thinned it out at first, but then as the systems there needed a little bit more support from the residency services, they requested that they bring our first years back over there. And so we've been having them kind of rotate 1 week on, 1 week off between the interns. Because we only have 4 interns in each class, we have 2 interns on the inpatient psychiatry service, and then we have 2 other interns that are going 7 on, 7 off, and trying to kind of cover both of those inpatient needs. Anything else you'd add for the essential rotations, Jake?
No.
Okay. And then in terms of non-essential, so majority of our electives were immediately pulled, as well as some of our subspecialty rotations. And while those are important for our second years, like child and adolescent, addictions, and geriatrics, we were further in the year, being kind of late March where we decided this. So majority of our second years have gotten ACGME requirements, since we do so many months of addictions and several months of child is in blocks, and we've done multiple blocks of geriatrics. We realized we didn't really need to, for some of those, we didn't really need to continue in order to make sure that our second years could progress to third year. What else? There was our forensics, our experience was put on hold. CSP for our third and fourth years, or that community outpatient experience, that was pulled because it was felt that those providers there could maintain their load on their own and didn't necessarily need residents there. And then NDI as well, which is the Neurodiagnostic Institute. Residents were kind of rotating there and supporting the state hospital providers. But again, it was felt that they could manage on their own, and that was also a particularly high risk setting, it being kind of a state hospital setting, just in terms of having residents go in and out and potentially be covering it, inpatient psychiatry shifts and then go in there. It felt like that was very risky, and overall it was important to kind of stop that cross-site exposure.
And just add just a slight bit onto what Dr. Corrales is saying. With the non-essential rotations, these were all pulled initially and out of the gate, and we had to develop curriculums, and I think we'll touch on that in coming slides, but many of them have been rebooted with telemedicine and access remotely, and so our residents are back in action on the services once again in certain regards, but in not all capacities. I know with the severely mentally ill setting over in the CSP clinic, we're back, as well as child and adolescent addictions. Neuro is about to start next month again. And a couple areas we still have not yet gone back to have been the NDI, I think forensics as well as geriatrics. And understandably, we've been doing a lot of, it's predominantly nursing home work. And so with that being a hotbed population, it's just not safe for us to go in there and add exposure.
Mm-hmm.
And so I guess I was right whenever I said we're going to talk about this more in depth, and some of this we might have already covered, but again, the essential rotations transitioned largely to telemedicine and remote work. And I'm going to give an example in a couple of slides of what our inpatient psychiatry service is like and what kind of changes have been made from what we discussed earlier from pre-COVID, just as an example. And we've had some changes to our call schedule as part of our emergency psychiatry through crisis. And we've continued to be in person for those shifts, weekend shifts for emergency psych for second years. But the first years have taken, like Dr. Corrales said, a lot of the second year's shifts as far as call shifts that we had been doing, and usually they're once every 2 weeks. So they've been working a lot more call lately, but that's because second years have taken up more responsibilities elsewhere. And like Dr. Corrales said, there was an initial halt on the inpatient medicine service, and but now we've got two residents at a time instead of just one on their family medicine service this month, and then there will be, I believe, 2 more residents then switching on next month, and they do a different kind of schedule than previously.
And I want to say that that transition to telemedicine took at least 2 weeks, right?
Yeah, and that is huge, because as far as the transition to telemedicine, it was something as far as the pavilion at large, especially compared to outpatient. It seemed like outpatient transitioned quicker with our Hillsdale clinic, not as much the other realms of outpatient, but our inpatient side of things, there was a lot more angst of how are we going to round as a team? How are we going to get proper resident supervision? How are we going to get proper interdisciplinary coordination and care with social work, case management, nursing, and going from unit to unit? Do we have technology staffing? Because we're also on a hiring freeze at the pavilion as well, so they're short-staffed, and there's a lot of things going on. And we actually had daily telemedicine committee prior to rolling this out for about 2 weeks. Like Dr. Krause said, I was on it in terms of how do we best transition our residency service, but also the other inpatient physicians that are not affiliated with the residency service. How will we be transitioning remote? And eventually the decision was made. I remember it was a Thursday. We're still kind of talking how are we going to do this? And it was decided that on Monday we're doing this, and we're rolling it out. And so we did initially have our whole team go into the hospital for a couple of days and kind of give it a trial run, doing remote in our residency call room, but able to, if there was glitches anywhere, to be able to go in person and see patients. And then by the start of the month of April 1st, we rolled this out entirely remotely via the WebEx platform.
And then in terms of our non-essential rotation, so obviously initially we just stopped everything, and like Jake already kind of mentioned, we didn't really have visibility on when would we resume them. Would it be reasonable to do some of this remotely, and just kind of shadowing providers? Was there any use to that? If we needed to do those to meet requirements, how do we still have an educational experience for residents, and be able to prove that they're doing covering materials, whether it's online CMEs or whatever else it is. We just had to stop things and make sure that we were minimizing exposure, and then it took some time to kind of react to that and figure out what the next step was. Some of them, like Jake mentioned, were easier to transition, and it kind of followed suit with the outpatient setting. If child and adolescent, we work with both inpatient and outpatient providers. So we were able to more quickly transition and start shadowing, and then stepping in to see some of those patients in those clinics all remotely. But it took some more time for the inpatient child and adolescent rotation to be able to get started from a remote setting, and that kind of followed suit with our main inpatient service and the rest of the providers in our pavilion. So very much case by case basis, depending on what site are we talking about. Are they comfortable and able to use teleservices? Do the providers that we were working with, do they feel like it's reasonable to do it, or are they too stressed out and overwhelmed to try to reincorporate a resident given everything? But for majority of them, we have been able to incorporate some level of a clinic or patient care back in there. For addictions, if we were able to do some of that inpatient addictions rounding at Fairbanks, by totally doing WebEx platform as well. So some of them still haven't been restarted and are on hold. And as Jake mentioned, we're just doing that kind of design curriculum that we came up with. And a lot of the chief residents, as well as the program director and associate program director, we're working on kind of how do we design a curriculum, how do we provide these resources to our residents, so that way they're not just kind of at home and trying to figure out, well, what do I do now? We're trying to provide some more structure for the residents, and again with the thought there of how do we maintain the learning of the residents so that they can progress to the next academic year. ACGME have been putting out various updates here and there, but there wasn't a ton of visibility in terms of requirements and things like even like graduation requirements for our fourth years. That was talked on a national level in terms of, well, they've stopped doing electives. Are they going to be able to graduate? And ACGME ended up putting a lot of that onto our program directors and saying, well, it's kind of at the discretion of them whether they feel like, if they've missed a couple of months of electives, are they ready to graduate or not? So there's a lot of things to kind of juggle with all of this.
And one more thing I wanted to add is there have been other new opportunities for rotations, new elective rotations, when other ones were lost, I guess, to COVID, other ones were gained. An obvious one is the disaster psychiatry elective. And other programs are doing this as well, but in our program specifically, we work with a lot of community outreach. I'm currently on the disaster psychiatry elective this year, and I'm opting to do a geriatrics elective later on to fulfill some more of that experience. And so it's a lot of flexibility in changing schedules, and I'm getting an amazing experience. I mean, not everybody can have a disaster go on to actually do a disaster elective. So not that that's a good thing overall, but there is some positives coming from that as far as a learning experience.
Yeah, for sure. Definitely.
And then I just wanted to include a slide from telemedicine. We largely, especially on the inpatient service, use WebEx. We also use that a lot as an outpatient. Our residency service specifically uses personal rooms, so that way we don't have to send a meeting invitation and number out via email every single time we see a different patient. That way a personal room is almost just like having an actual room. It's a virtual room where you're the host of it, and you kind of control the door, who you let in, who you let out. You can boot people out if you want to, and it's nice there because you can have an entire treatment team. We have our social workers, nurses, whoever, as well as the patient, other residents, attending physician, pharmacist, all on the personal room while we see patients. And then other platforms that are commonly used are Zoom. That's for some outpatient services, as well as a lot of meetings I've been doing recently have been on Zoom, as well as some of our didactics. And I should say didactics for WebEx as well. Microsoft Teams, I've had one presentation that I've done on Microsoft Teams, but that's not as commonly used. GoToMeetings, there's some meetings around the pavilion that are on that platform. And then Doximity Call, some of our outpatient residents are using that as a better way, I guess, to get access to patients who may not have a computer, and it's easier to just kind of click on a link from a text message or something directly to the patient's phone, and they can connect audio, video. And there's numerous other telemedicine platforms, and there's been some lessening of restrictions on what can be used via like HIPAA compliance laws during the COVID pandemic here, and some of them are actually getting some business agreements to comply with those HIPAA laws to continue to be used going forward. I know even like things like Skype and are being used.
Yeah, and Doximity, I think, had a pretty awesome platform beforehand, but I've just heard a lot of good things about that, and it's pretty nice too in the inpatient setting as well, because a lot of us, we don't have access to kind of those hospital lines or phones when we're at home. So with Doximity, you're able to make those calls to family members for collateral information, and able to you can choose what your number is, so you're able to kind of show that it's as if it's calling from the hospital, in case that they need to call back. So, and you're also able to kind of not show all your personal cell phone or whatever phone you're using. So there's a big advantage with that, I would say. And then the WebEx, I would just add too, I think it was easy for us to use that for so many things, just because it was the platform that everybody was familiar with from like beforehand, with meetings, with different things we had gotten familiar with it from before. So most people knew how to navigate WebEx and how to set up meetings and how to join meetings. In terms of our inpatient psychiatry service, today, a lot of changes and iterations have happened, and obviously, a big thing that came from a lot of the medical schools was they pulled their own students, and this was kind of a mutual decision. Our GME and our network decided that we didn't necessarily want to house medical students on site, just to minimize exposure. I think this is pretty similar with across the country. A lot of hospitals have become no visitors, the patient only, and they don't even sometimes allow significant others to go into the hospital. So it made sense that medical students were not going to be there as well, which is certainly unfortunate from an educational standpoint, but something that happened from a high network level, but then also a lot of medical students, their rotations were just canceled from their end too. So we still haven't had any medical students since then. So since mid-March, it's been pretty much only residents, and then the core team of pharmacy and attending. Like Jake has said, we've been using the WebEx personal room for our rounds, and it's really nice as we can have all the nurses become familiar with that personal room, so we don't have to send new links every day, and they're able to just easily join and leave and when they want to. And then also we have our social workers who can quickly find us and join those rooms as well. And we work so much with them that they're very familiar with joining our room and seeing patients with us. We integrated a process meeting. So initially we had 2 meetings, one in the morning, one in the evening, just to talk about process things that would come up, any obstacles or barriers. Eventually we were able to eliminate that morning meeting and just do an afternoon huddle. And these were meetings that lasted maybe 5-10 minutes, very brief, just main urgent issues that came up, as well as any updates that were coming from a systems level that that our program director had to kind of disseminate out. And still, I think we still have them, and they still are pretty valuable because there's still a handful of things that may come up. The things that have come up are smaller and smaller every day, but it's still been a nice structure to have there to make things constantly improve. And then we've been running as a full team. So beforehand, like we kind of mentioned earlier, we would have individual residents as well as medical students and sometimes pharmacy residents round individually and see all their patients on their own. And the resident essentially seeing their patients, then later presenting to the attending kind of a brief summary of what happened, what their plan is, what's going to happen. And then the attending would spend maybe just a few minutes with a patient, just checking into any smaller details before moving on to the next one. Now we've been doing everything as a team. So all members of the team are seeing the patient for the entirety of the interview, as well as the entirety of discussion about what the plan is for them and what are the next steps. So that's been a big change for us because it changes the amount of time that each individual resident is spending with patients. Beforehand, you spend a lot of the time on your own, just kind of doing interviews more one-on-one with patients. And then kind of that group experience is a little bit shorter for the patient, but now it's all together, and you're seeing, I think, the other residents' patients a little bit more closely. And like we mentioned, we've incorporated the social workers into some of those interviews too. So it's become, I think, more collaborative and interdisciplinary, because oftentimes we would beforehand we may send a message to a social worker giving a quick update after we had seen the patient, and then we also had those Monday, Thursday meetings structured in the afternoons to kind of do this interdisciplinary communication. But now it's built into our day. It's very seamless to kind of for me to talk to the patient, but then transition to the social worker to for them to ask any questions, and if I had any questions for them, it's just the line of communication has been so much easier for that. And then in terms of core call, so So court is something that we do as a means in psychiatry for involuntary commitment, where we will, file for a patient to have temporary commitment, and then there's a court hearing. And so historically, we had gone into the courthouse, and then the patient would also have to be transported to the courthouse. We're now doing everything remote, and actually the court has done this too. All the judges, all the lawyers, they're all working, remotely as well. So we will call into this court call system, and then the patients will call in as well with the help of nursing. They'll set that up, in their room or somewhere private in a conference room, and they're able to kind of call into the court call as well. So that's something that was, we had kind of started to work on some of our process with that beforehand. That was something that we had recently integrated into our practice. I would think not even quite a year beforehand, before this all happened. But it's just now been fully remote, where the patients are always, calling in remotely. So that's been a change, but it's also been it's one of the easier things that I think that has transitioned. And like I mentioned, the daily afternoon sign out. So after we do this afternoon huddle for talking about process issues, we'll do the afternoon sign out for just those residents who are seeing patients and updating the attending and the team with anything new.
Yeah, so certainly a lot of change there, and continues to change every day with those daily meetings. I don't want to spend much time on this, but our continued education, we've already touched on a lot of this, but our didactics on Tuesday afternoons, as well as our Wednesday presentations, grand rounds, our safety projects, journal clubs have been moved to remote video conferencing. We also have Pride review, board review, and like some pharmacy educational opportunities that have also been transitioned. And again, our Marian University students are not with us.
So residents have really been stepping up into a big, I would say, leadership role, as well as clinically. Having the second years redeployed was a pretty big surprise, especially for our psychiatry residents who, figured that they were done with any medical wards after the first year. So that was a big kind of, I think mental hurdle for a lot of our second years to potentially face, going back to those wards and brushing up on a lot of our medicine, as well as, facing the idea of treating a COVID positive patient. And then also kind of facing exposure as well. Fortunately, our hospital had sufficient protective gear, but a big amount of, like, I would say, burden on the second years to kind of jump into that. Residents have also been making a lot of adjustments, as we mentioned. Every day we're doing new process changes, which is difficult. It's not easy to change any given process, especially when people are still trying to learn it. And so we've been really just having, people have had to be really flexible to kind of keep up with things, and that's been a big thing. Residents have often been kind of a point person for different things that have been changing. So, there's been so many different things to worry about, safety, and then different things to communicate. So a lot of residents have been stepping up to be kind of liaisons, be able to communicate between different people, to attend a lot of these system-wide meetings that are happening, and kind of report back to our team about any updates, and also to bring any concerns or things to those meetings as well. So we really relied on the residents to do that, because certain things that maybe our program director or our associate program director would, kind of be the main person doing that work. They don't have as much time to do that, because they're working on some of these higher level hospital executive level meetings, and they're kind of totally booked up with that. So our residents have really stepped up, in terms of that too. And then we've really appreciated our in-person staff, trying to do a lot of thank yous, send them email sentiments and appreciation, then also send them food. Anything else you'd add there, Jake?
Really the main thing, I mean, and I feel personally connected, I guess, to this because I've personally seen my role grow. I mean, I'm not like a slacker by any means. I work really hard, but when it comes to a lot of the leadership things and administration types of processes, that's normally not been my cup of tea as much as I love seeing patients and direct patient care. And Dr. Corrales is much more involved. He's our junior chief resident, and really I just leave a lot of that bookkeeping stuff to him or our chief or program director and faculty. But that's not an option anymore, and I've really enjoyed taking up some of the responsibilities that have been brought forth and growing my role in certain regards as well. And I felt like there have been, without COVID, I don't know if certain things about myself that I feel more comfortable doing, I would have discovered. And so there have been areas of positivity during this for our residents. And again, and sorry that we're going through some of this repeatedly, but we have continued to change things a lot as we've transitioned, especially on the inpatient side of things, what works, what hasn't worked so well, what new problems arise. One of those was our treatment rounding format, and we've actually changed that here recently. Instead of a block time for 30 minutes, we round unit by unit for treatment rounds with nursing and social work case management, which is much more efficient, but it takes a lot more coordination, and so that's been done. Our weekend rounding format has obviously changed with our on-call physicians coming sometimes from the outpatient world, now having to adjust to remote inpatient WebEx setting and how to navigate that. But largely that's resident-driven. We've been working in our CSP clinic and residents behind the scenes trying to provide more wraparound services for ensuring that our chronically mentally ill, severely mentally ill patients get their long-acting injectable medications timely to try to prevent decompensation there. And around the hospital too, we've had some changes. Our overflow unit has been converted to a COVID unit where we have patients under investigation for COVID or COVID positive confirmed cases there. And then we also have a step-down unit from there as well on our dual diagnosis unit, and sometimes we use our youth units for that. We've had to be more judicious on our patient length of stay. I mean, we don't want people to remain in the hospital longer than they need to be, and that's normal too, but especially now, we want to make sure the risk-benefit ratio is adequate, and we can get patients out of the hospital and back home away from being exposed to others as frequently as they will in the hospital setting, but also keeping the acute safety risk in mind, which is higher at times during this whole pandemic. And then the disposition of certain patients has been different, and especially for homeless patients and specifically, and COVID running rampant in that population, there's a lot of shelters and missions and group homes that are not letting in new patients. And so we're getting, with this population, we're having to be innovative and work very closely with our case management staff. And sometimes that can be difficult. And
I know that was a big, hurdle, especially early on when the COVID tests were taking so long. And now they're, within 24 hours. But beforehand, it's like, do we keep them 2 or 3 days, just to see what the COVID results are or not? But a lot of places wouldn't allow them to go to a shelter if they didn't know what that result was. So there's a lot of trickiness there. Yeah. In terms of highlighted improvements, so yeah, I think there's definitely a lot of good improvements, and I think a lot of benefit that we've seen from all these changes. There's definitely limitations, but we've really enjoyed the collaboration and communication we've had with our team members, especially with social work, case management, and the nursing staff. Feel like that has been really successful and really helpful and something that we want to retain. The quality of patient care really improves from that as well. I think we feel like patients probably have shorter length of stays because we're not necessarily wasting any time trying to communicate and coordinate disposition, despite some of the difficulties with, especially the homeless population. It definitely helps to have better coordination between collateral and social work there. So in terms of our supervision, since we all are rounding as a team, the attending is observing directly all of the interviews, the entire interview, and that's a big benefit in terms of their ability to get feedback, to really have that closer level of supervision for especially our first years. And so that's something that we're thinking about too, because initially, like we said, we were worried about, well, if we're all remote, how are we going to properly supervise the residents? We were worried that maybe it would be reduced, but in fact it was, quadrupled or something like that. So it was, a pleasant surprise, I would say. Limitations, obviously, technology. There's always things that go wrong, delays that happen because of something failing. It can be pretty frustrating. Can delay rounding. Sometimes over an hour, depending on what's going on. We need the technology in person there, so those computer on wheels sometimes needed to be shared between units, depending on if we were low in stock on some of those things or if multiple things are being serviced. The interaction clearly suffers when you're on a screen as opposed to in person. I would say I was surprised by how well we feel like we can interact and kind of communicate with patients virtually, but it's still a big limitation through all this. Physical exam is something that we can't do, which is a big thing to keep in mind for us. We're trying to improve our visual inspection exam and keeping a close eye on things, and also speaking with nursing on anything that we visually want better eyes on. But it's been a big hurdle for any telemedicine. And then I think we mentioned kind of the COVID-19 impacts on care and disposition. In terms of our units, we have an initial kind of COVID unit or a PUI, a persons under investigation unit. So if somebody's getting a COVID test and we don't know what the result is, they'll be on a designated unit with the highest level of PPE for our staff as well as patients. And then we've developed multiple step-down units. So as soon as they are COVID negative, they're able to step down into another unit that only patients are on there if they've been on that initial COVID unit, to try to minimize exposure to the rest of the patients in our facility. So that's something that we've done a good job to try to minimize that exposure, but it really takes up a lot more hospital services. A lot more beds have to be kind of partitioned to do that, and it has required a lot of our administration to kind of coordinate around. We had a TMS clinic as well that we were very close to opening up. We had already purchased a TMS machine that obviously has been put on hold, and unclear when that will at this point happen, even though it was a couple of months away from kicking off. And then ECT access as well. So we had several residents wanting to go in person to get ECT training, and also observe ECT on rotations, and we're not able to do that at this time just because we have pulled residents away from electives and non-essentials.
And I'm not going to spend much time on this, but we have been trying to talk more wellness and integrate more wellness into our weekly routines and daily if possible. And some of the things that our residency program does, and specifically we've had a WebEx trivia night or two, Pictionary on multiple occasions we can do virtually, psych movies, as well as we have what's called RISE groups, and that's more of like support group but geared towards the residents in specific during this time. So it's like a resident specific support group, and then there's different physician support groups, usually either in the early mornings or in the evenings. And then we've been getting a lot more frequent check-ins from faculty and other residents as well, virtually of course, and so constantly asking us if we need anything and if we're feeling well supported, and I would say definitely.
Mhm. In terms of what is on the horizon for us and what we're expecting, it's pretty clear at this point we're not just going to snap our fingers and go back to how it was. I think telepsychiatry, we realize is definitely here to stay, and it will be incorporated in the future. And that process of going back in person is going to be a very gradual one. Our graduation unfortunately had to be canceled in terms of the in-person celebration, which a lot of us are disappointed about. We're trying to think of different ways on how we can celebrate our graduating class, and kind of make it special for when they actually finish their contracts. But we're at this point, they've requested that we push it to the fall where we can all meet in person, and just we're going to try to do something small in the next couple of months. We have new interns, like I said, coming in and actually mid-June for orientation, then they start clinical July 1st. And so, that's something that we're going to, we're constantly trying to figure out how we're going to onboard them, even though we're trying to not really interact in person very much at all. So a lot of the in-person orientation stuff has been canceled from the GME level. So that's going to be a big challenge that's on our to-do list here. And then, transitions are going to be gradual. Where right now we don't know on the inpatient side when we will go back in person. And we're kind of just waiting and seeing in terms of what the broader pavilion decides on that as well. And then we'll see if we're going to get a second wave or not, or what will happen next. We're always expecting kind of the unexpected at this point.
And one last thing I wanted to add is that our inpatient, our PGY2s are going to be going into the outpatient world. And so we're normally we normally meet all of our patients in person doing warm handoffs, and those warm handoffs are now virtual and a little less intimate, I guess, as far as when you're just meeting somebody for the first time. And so that's going to have some difficulty there. But overall, I've really been pleasantly surprised and excited about how our residency has responded from the top down during COVID-19 and continues to respond day by day, week by week to COVID-19, and excited about the future. I'm excited about getting back to seeing people in person, excited about more wellness opportunities that are not hospital or homebound. So football, maybe basketball, I don't know. So thank you for listening to us, and I hope we didn't waste your time.
Yeah, thank you all.
Take care.